Good afternoon, everyone. I'm pleased to present my PhD thesis topic, Impact of Navigational Systems on CT-Guided Interventions. My name is Mátyás Rédei. I'm a first-year PhD student and a clinical physician at the Medical Imaging Center. And throughout my PhD research work, I would like to improve CT-guided interventions with advanced navigational systems by investigating its impact on such interventions. Therefore, we aim 3 specific goals throughout my first year of my PhD first-year PhD studies. The first one is investigating the safety and effectiveness of navigational systems for patients undergoing CT-guided interventions. There are various types of navigational systems, but they have distinct characteristics which make their comparison challenging. However, they share a common first step, the needle insertion part. The success and the efficiency of this intervention hinge on the precision of the needle insertion. Moreover, less precision can cause multiple needle navigation, more complications. Furthermore, the waiting lists are even extended, resulting in delayed diagnosis and therapy. But by utilizing navigational system, the irradiation dose can be reduced by half. The procedure duration can decrease by about 40%, and also the complication can be reduced. So our clinical question is that does the integration of navigational systems in CT-guided intervention lead to a reduction in complications compared to the conventional method? Therefore, we are comparing the utilization and non-utilization of these interventions on patients undergoing CT-guided interventions to assess outcomes such as number of needle manipulation and procedure time, and additionally, we would like to investigate irradiation dose, complication rate, and success rate as well. Here are the strategy of our systematic search conducted on 4 major databases according to the search key presented on the slide. According to the PICO framework, the first domain is for the population, the second is for the intervention, the third one is for the comparator. We managed to decrease 20,000 hits to 32 eligible full text, and we finished the analysis of number of needle manipulation. Number of needle manipulation is crucial to define the length of the process, the complications, and also the irradiation dose. The number of needle manipulation is described as number of adjustments during a procedure, averaging about less than 10 per procedure. We included 19 studies in this forest plot, 11 cohort studies, and 8 cohort studies, 8 randomized control trials. We found a very great heterogeneity, which is contributed by the fact that this article involves a different type of interventions, different navigational systems, and also different targeted organs. We found significant difference in the overall mean difference by 3, favoring the navigational system group, which result in a more minimally invasive procedure. And this reduction in the results are also a reduction in needle manipulation is also clinically relevant because it can lower complication and also lower procedure time and irradiation doses. We have a subgroup analysis for different type of studies. On the first you can see the cohort studies, and below there the RCTs. If you see the prediction interval of the RCTs may overlap the null effect sign, but based on our clinical experience is highly unlikely. So our overall conclusion, or preliminary conclusion, that for practice, this result can change the guideline recommendation, and also we should protocolize navigational systems in these interventions. And for for research implication, for the future, we can compare different navigational systems with more homogeneous interventions. So our strength is a practice-changing potential, and this result is clinically highly relevant. And our limitation is, our study and result is limited by the fact that this result may not be applied for each individual navigational system, but if we see the pooled result from the RCTs are parallel with the cohort studies, this limitation is not very severe. This is the progress of my first project. We are doing the duplicate for the data extraction and the risk of bias assessment parallelly. Let's jump to my second project, comparing complication rates per protocol versus standard method in CT-guided pulmonary biopsies. This is a protocol of the randomized control trial. Percutaneous CT-guided lung biopsy has the advantage of a technical success rate nearly 100%, diagnostic accuracy nearly 19%, and it's conducted under local anesthesia, which is much better for the patients. But on the other hand, it has high risk of complications, such as pneumothorax and chest tube insertions. To lower this complication during CT-guided interventions, we can use the above-mentioned navigational systems or the per protocol. The per protocol is a pool of tools we can conduct after the CT-guided interventions. It stands for patient positioning, biopsy side down, needle removal during forced expiration, autologous blood patch sealing, rapid rollover, and pleural patching as needed. As in the article you can see in 2023, it's also published this protocol. In this result, they managed to reach much more lower complication rates like pneumothorax and chest tube insertion, and with the same diagnostic accuracy. So our clinical question is, does the per protocol reduce pneumothorax and chest tube insertion rates compared to the standard method? The PICO framework is similar. We are comparing the standard technique to the per protocol in patients undergoing CT-guided lung biopsies to assess complication rates such as pneumothorax and chest tube insertions. And therefore, we can implement this protocol to our everyday practice. The study I was talking about in 2023, it has the strength of a large sample size, more than 200 patients were involved, and it has a clear and measurable outcomes. But on the other side, it's a single standard study and a retrospective cohort study, and therefore we want to conduct this study on our clinic to provide a new centered data and in the framework of the randomized control trial. And let's jump to my third project of mine, comparing the accuracy of a novel navigational system and conventional CT-guided method in pulmonary biopsies. Lung cancer, the incidence of lung cancer overreached 2 million cases worldwide in 2022, Hungary leading it per capita rate, as you can see. The diagnosis depends on the localization of the lesion. Transbronchial one are for central lesion, and transthoracic are much more chosen for peripheral lung lesion. Also, it has a high complication rate. Transthoracic CT-guided pulmonary biopsies has higher technical success rate. Our device is validated through a Phantom study, resulted in lower number of needle manipulation and lower total insertion type. And without ethical approval, we seek to validate our device throughout retrospective measurement, CT scan and planning. We measure the planned axis we want to reach, and then we insert the needle during a CT-guided intervention, and then with the device we can measure the actual axis of the needle, allowing us to compare target point error and angular error in between the two clearly defined axes. So the clinical question, I think, is familiar. We are comparing the utilization and non-utilization of these navigational systems in patients undergoing pulmonary biopsies to assess target point error and angular error as an outcome. This device, for clinical implication, this device could potentially offer a crucial advantage by accurately measuring the needle's position. Thank you very much for your attention. I would like to end my presentation with the words of Lisa Links. There's so much gray to every story, nothing is black and white.
Thank you very much. I have a question. So, what about if our patient is breathing during the procedure? During
pulmonary biopsies?
Yes.
Or, yeah.
Yes.
I think this is the most difficult problem to come over because it's conducted under local anesthesia, and we are intending to do the CT scan in the same phase of the inspiration and expiration. So on our clinical practice, we are conducted in after expiration to reach the similar position of the patient.
But the time of the insertion was 5 minutes in your slides. So it seems a bit for me too long, or maybe I should a little bit more practice.
And the patient can breathe
know.
in between, but the patient has to stay in after expiration and hold the breath for some minutes.
Can I ask you, what's the reality if you do these interventions manually, or do you think that in the near future we can do it by some robotic technique procedures?
There are also robot-assisted navigational systems I also included, but they are much more likely to validated to liver interventions, but they also need the assess of an interventional radiologist and the CT scan as well.
So thank you for your presentation. My question is regarding your third project. So why did you choose to compare this per protocol to a conventional method, which is not a navigation system?
If only we could compare it with the navigational systems, but there is no validated navigational systems for CT-guided lung biopsies right now. But I would be the happiest person on the world if we could compare to our navigational system.
Thank you.
Congratulating for your nice presentation. And as a pulmonologist, I have curious about according to the first project. So with this, do you have any data or preliminary results about how much the formation of the pneumothorax are reduced with this new navigational system?
I can't say exact numbers for our meta-analysis, but for pulmonary interventions with navigational systems, the pneumothorax rates are lower by around 30%.
Thank you for your presentation. I have a question about the per protocol. You mentioned that one of the steps is patching the pleura. What kind of materials can be used to do this?
For pleural patching, autologous blood patch sealing is the best option, I think, so far.
Thank you.
How do you perform it? Just injecting the blood?
While you are removing the needle, you can inject the blood on the surface of in the interpleural region.